Ever felt like you're just drowning in information?
Yeah.
Especially when it's about something as vital as your horse's health.
Oh, absolutely.
You read articles, you hear bits and pieces, but really getting a handle on something complex,
hmm
it can feel overwhelming.
Like climbing a mountain without a map, as you said.
Exactly. Well, if that sounds familiar, you are definitely in the right place today. We're diving deep into equine insulin dysregulation.
Yep, ID.
Our goal today is simple. Give you that clear map. We're going to use the detailed research you gathered on equine health to really cut through the noise and pull out the most important insights about this condition. It's something critical for, well, really any horse owner or enthusiast to understand.
That's the plan. We want to unpack what insulin dysregulation actually is, why it's such a big deal for horses,
Right.
how vets figure it out, the diagnosis part, and crucially, what you can actually do about it, the management side.
Especially managing it to prevent something as awful as laminitis.
Exactly.
Mm-mm.
Safeguarding their health, preventing laminitis, that's the ultimate goal.
Okay, let's start right at the beginning then. We hear insulin all the time, humans too. But what is it? And what's its job in a healthy horse?
Okay, so insulin. It's a vital hormone, fundamental in all mammals, really. It's made by specific cells, beta cells, in the pancreas.
The pancreas.
And its main job, it's the chief regulator of blood sugar, glucose levels.
So when the horse eats.
Right. The biggest trigger for insulin release is a rise in blood glucose after a meal, particularly one with non-structural carbohydrates, NSC. Think sugars, starches.
Those energy-dense feeds.
Exactly. And interestingly, the research points to gut hormones called incretins playing a big role too. They kind of amplify the insulin release when food is present.
So it's a team effort.
It is. Now imagine insulin as a key.
Okay.
Glucose from the meals is floating around in the blood. Insulin unlocks the doors on cells, mainly muscle and fat cells.
Letting the sugar in.
Precisely. Lets the glucose rush in. And once inside, it can be used right away for energy or it gets stored.
Stored how?
As glycogen, mostly in the liver and muscles, for quick energy later. Or if there's too much glucose, it gets converted into fat for longer-term storage.
And that brings blood sugar back down.
That's the goal. The whole process brings blood glucose levels back to normal.
So it's more than just getting sugar into cells then.
Yeah.
You mentioned something else.
Yes, exactly. And this is really fascinating, especially when we think about horses and laminitis. Insulin does more than just manage sugar. It has what we call vasoregulatory actions. Think of it like influencing blood flow.
In the hooves.
Particularly in those tiny critical blood vessels in the hoof, yes. It affects nitric oxide production, causes some vasoconstriction. Basically, it helps control blood flow in sensitive tissues.
Wow. Okay. That sounds important.
It's increasingly seen as a huge piece of the laminitis puzzle. In a healthy horse, it's all tightly controlled. Eat NSC glucose rises. Insulin released, glucose enters cells. Glucose normalizes insulin drops. A perfect feedback loop.
Okay, so that's the ideal scenario, how it's supposed to work. But, as we know, things don't always go to plan, right?
Unfortunately, no.
This is where it gets really interesting. What happens when this whole system starts to break down? What exactly is insulin dysregulation, ID, and why is it so central to things like Equine Metabolic Syndrome, EMS?
Right. Well, when that precise system falters, that's insulin dysregulation, or ID. It's basically any abnormality in how the horse's body handles insulin.
Right.
It's a core feature of Equine Metabolic Syndrome, EMS, and it's a major risk factor for that laminitis we keep mentioning, specifically hyperinsulinemia-associated laminitis, HAL.
Hyperinsulinemia meaning high insulin?
High insulin, exactly. Now, ID can show up in a few different ways, sometimes combined.
Like what?
Okay, first you might have resting hyperinsulinemia. This means insulin levels are too high even when the horse hasn't eaten for a while, like overnight fasting.
So the baseline is just too high.
Right. It tells us the pancreas is working overtime, pumping out extra insulin just to keep blood glucose normal.
Okay, what else?
Second, and this is probably the most common one we find, is postprandial hyperinsulinemia.
After eating.
Yes, an exaggerated insulin response after a meal, especially a high NSC meal. The insulin spikes way too high or stays high for too long, even if blood glucose eventually comes down.
Like the system overreacts?
Kinda, yeah. And third, there's tissue insulin resistance, also called insulin insensitivity.
Ah, I've heard of this.
This is where the cells themselves muscle, fat, liver become less responsive, almost deaf to the insulin signal.
So the key doesn't work as well.
Exactly. They don't take up glucose properly.
Yeah.
And what does the pancreas do? It pumps out even more insulin to try and force the glucose into the cells.
A vicious cycle.
It can definitely become one.
So just to clarify,
Yeah.
if a horse has high blood glucose, that points more towards the resistance part. But if glucose is normal but insulin is high, that's more the EMS or maybe PPID picture. Is that roughly right?
That's a useful way to think about it, generally speaking. High insulin often points to resistance trying to be overcome. If you see high insulin and high glucose, that suggests the resistance is quite severe. The body isn't compensating well anymore.
Right.
But if glucose is normal despite really high insulin, yeah, that often suggests the body is compensating hard. You see that with ID and EMS, or sometimes with PPID, pituitary pars, intermediate dysfunction.
Cushing's disease.
Right, equine Cushing's disease. Just for context, there are other less common scenarios too. Really low insulin might suggest pancreas problems, like pancreatitis. And very high insulin with low blood sugar could point to a rare tumor called an insulinoma. But mostly, we're dealing with high insulin related to resistance.
Okay, that makes sense. So what actually causes this system to go haywire? What are the main culprits behind ID?
Well, there are several key factors involved. First off, genetics and breed play a really significant role.
The thrifty gene idea.
Exactly. We see ID much more often in breeds like ponies, Morgans, Arabians, some quarter horses, draft breeds. Horses genetically wired to be super efficient at storing fat. Great for survival in the wild, not so great with modern feeding.
Mm-hmm.
Then there's obesity, especially that regional fat.
Like the cresty neck.
Yes, a cresty neck score 3 out of 5 or higher, or those fat pads over the ribs or at the tailhead. Those are big red flags.
Why is the fat itself such a problem?
Because adipose tissue, fat tissue, isn't just storage. It's actually metabolically active. It produces hormones, adipokines, that can directly interfere with insulin signaling and make resistance worse.
Wow, but you said it's not always obese horses.
That's a critical point, yes. ID absolutely can happen in lean horses too, so you can't just look at a horse's weight. It's important, but not the whole story.
Good to know. What else?
Diet is a huge one. Diets loaded with those non-structural carbohydrates, grains, sweet feeds, lush pasture, they are major triggers for those big insulin spikes and can worsen resistance over time.
Makes sense.
And naturally, a lack of exercise. Movement improves insulin sensitivity. So less exercise means less sensitivity.
Okay. Any other big ones?
Definitely PPID, Cushing's, very common in older horses, say over 18 or so. The hormonal imbalances in PPID, like high ACTH and cortisol, directly cause or worsen insulin resistance. So you often have to figure out if it's just ID, just PPID, or, very commonly, both together.
So they often overlap.
Frequently. And finally, things like systemic illness, significant stress, even severe pain, they can all trigger temporary insulin resistance. That's relevant with acute laminitis too. The pain itself can push insulin higher.
Right.
And one more interesting point from the research, even just fasting a horse for too long, like over 6 hours, can cause some temporary tissue insulin resistance in pretty much any horse.
Really? Okay, that's surprising. So all this, it funnels down towards laminitis, that dreaded outcome. Can you spell out that link more clearly? How does high insulin cause laminitis?
Yeah, this is the crucial connection. The research is very clear now. Hyperinsulinemia, high insulin, is a direct cause of laminitis. It's not just associated with it, it triggers it. We've seen this in experimental studies.
Oh, what's the mechanism?
It seems to be multi-pronged. Those vascular effects we talked about are key. High insulin messes with blood flow in the hoof, causing vasoconstriction, altering nitric oxide, basically reducing that vital blood supply to the delicate laminae.
Starving the tissues?
In a way, yes. Plus, high insulin seems to have direct negative effects on the lamellar cells themselves. Their metabolism, their structure.
The bits holding the hoof together.
Exactly. Those intricate structures that anchor the hoof wall to the coffin bone inside. And on top of that, inflammation coming from fat tissue, especially in obese horses, can add to the systemic inflammation, making things worse in the hoof.
So what's the end result of all that?
The result is the stretching, weakening, and eventual separation of those laminae. This causes incredible pain, instability inside the hoof. That's the laminitis we see clinically. The hoof's internal structure starts to fail.
Okay, that paints a clear and frankly scary picture.
Mm.
So given how serious this is, and they can be subtle sometimes,
Right.
how do vets actually diagnose it? What's the detective work?
All right, the diagnosis, it always starts with clinical suspicion. A vet looks at the horse and sees potential signs like
Yeah.
obesity, maybe a body condition score of 7 out of 9 or higher, or those specific fat deposits, that crusty neck again.
Hmm.
A history of laminitis is a huge clue. Maybe they have abnormal hoof growth rings, those founder lines, or x-rays show changes.
Right.
The horse's breed, its age, though, remember, it can happen at any age.
Yeah.
And sometimes other subtle signs like maybe slightly swollen eyelids, a puffy look above the eyes, or even issues with fertility in mares.
Okay, so you gather the clues.
Yeah.
Then what?
Then we move to endocrine testing, blood tests. And proper sample handling here is absolutely critical, separating the serum quickly, keeping it chilled or frozen.
Got it.
And also, different labs have slightly different reference ranges for insulin. So your vet interprets the numbers based on their lab's specific ranges. That's important.
Okay, so what are the main tests they might run?
The most basic one is a resting insulin and glucose test, sometimes called basal levels.
How's that done?
Simple blood draw after the horse has fasted overnight, usually 6 to 8 hours. No grain for maybe 4 to 6 hours beforehand.
And what are you looking for?
Well, if the insulin comes back high, but the glucose is normal, that strongly suggests insulin resistance where the pancreas is compensating. High might be over, say, 20 to 50 microunits per mil, depending on the lab.
Okay.
If both insulin and glucose are high, that points to more severe decompensated resistance. But here's the catch.
There's always a catch.
A normal fasting insulin test does not rule out ID. Lots of horses only show the problem after they eat carbs. Plus, stress or pain from something else can falsely bump up the insulin reading.
Right, so the timing and context matter.
Yeah.
So if the resting test is normal but you're still suspicious, what's next?
That's when the oral sugar test, or OST, becomes really valuable. It's often the powerhouse test for ID because it mimics a meal.
How does that one work?
It's designed to catch that postprandial hyperinsulinemia, the after-meal spike. Usually the horse fasts overnight, maybe just a flake of hay after midnight. You take a baseline blood sample.
Okay.
Then you give the horse a measured dose of light corn syrup orally, like Caro light syrup. The dose is based on body weight, maybe 0.15 milliliters per kilogram, or a bit more for subtle cases.
Do you syringe it in?
Usually, yes. Then you draw blood again at 60 minutes, and sometimes also at 90 minutes after the syrup.
And what shows ID on that test?
An exaggerated or prolonged insulin spike. For instance, if insulin goes above, say, 45 to 60 at that 60 or 90-minute mark, that's a strong indicator of ID.
And this one's better because it challenges the system.
Exactly. It's more sensitive for many horses. Plus, it's relatively easy. Sometimes owners can even do it at home with vet guidance. It's a practical way to see how the horse handles a sugar load.
Are there other tests vets might use?
Yes, though maybe less commonly in the field. There's the insulin tolerance test, or ITT. This one directly checks how sensitive the tissues are. You get a baseline glucose, then give insulin intravenously, and measure how quickly and how much the glucose drops, usually after 30 minutes.
Right.
A normal horse's glucose drops significantly, like by more than half. A resistant horse's glucose won't drop nearly as much or as fast.
Sounds useful, but maybe riskier.
It does carry a small risk of causing low blood sugar hypoglycemia, so it needs careful vet supervision. Then there's the combined glucose insulin tolerance test, CGIT. That's kind of the gold standard for research. Very precise, but it's complex, needs lots of blood draws, so less practical for routine field diagnosis.
Gotcha. And you mentioned PPID, Cushing's, earlier. Do you test for that at the same time?
Absolutely. It's crucial, especially in older horses, to rule out or diagnose concurrent PPID. They so often go together.
How do you test for PPID?
Usually with a baseline ACTH blood test, especially helpful in the autumn when levels are naturally higher. Or sometimes an overnight dexamethasone suppression test. Testing for both conditions helps create the most effective management plan.
Okay, that makes perfect sense. So let's say the diagnosis is confirmed, the horse has ID. What's the game plan? What does managing this look like long-term, especially to prevent laminitis?
Right, the management. The key thing to understand is that it's lifelong and multifaceted. There's no quick cure. It's about consistent control.
Yeah.
The focus is on 3 main pillars: diet, exercise, and sometimes medication. And the goal is always the same: lower those insulin levels and dramatically reduce the risk of laminitis.
So where do you start? Diet.
Absolutely. Dietary management is the cornerstone, non-negotiable. The number 1 rule is drastically reducing non-structural carbohydrates, NSC.
Sugars and starches.
Exactly. Forage, usually hay, should be the main part of the diet. And that hay needs to have an NSC level of 10% or less on a dry matter basis.
10% or less. How do you know if your hay meets that?
You have to test your hay. Send a sample to a forage lab. They'll tell you the WSC, water-soluble carbs, and starch content. Adding those together gives you the NSC. You can't just guess by looking at it.
Okay, test the hay. What if you test it and it's higher than 10%, or you just can't find low NSC hay?
That's a common problem. If you can't get low NSC hay, soaking the hay can help.
How long do you soak it for?
For moderately high NSC hay, maybe 30 to 60 minutes in plenty of water. For really high NSC hay, you might need to soak longer, maybe several hours, even up to 12. Then, and this is crucial, you discard the soaking water because that's where the sugars have leached out.
Does soaking affect anything else?
Yes, it reduces the NSC, but it also reduces some minerals and digestible energy, so you might need to account for that, especially the mineral loss.
Okay, so low NSC hay or soaked hay. What else for diet?
Eliminate all high-starch grains, sweet feeds, sugary treats. Gone. No exceptions. Think apples, carrots very sparingly, if at all.
What about pasture? That's often high in sugar, right?
Definitely. Lush, growing pasture is a major risk, especially spring and fall or after a frost. So pasture restriction is usually essential.
How do you restrict pasture access?
For horses with active laminitis or CVID, a dry lot, basically a paddock with no grass, just the tested hay, is often the safest option.
Okay.
For others, a grazing muzzle can be incredibly effective. Studies show they can reduce intake by 30 to 80%. Or you might allow limited turnout, maybe just overnight when sugars are lower, or for very short periods on less lush pasture. But careful monitoring is key.
It sounds like it's not just what they eat, but also how much, especially if weight is an issue.
Exactly right. If the horse is obese, calorie restriction and weight loss are vital. And this is where people often go wrong. You need to feed hay based on their ideal body weight, not their current weight.
How much is that usually?
Typically around 1.25 to 1.5% of their ideal body weight in hay per day, calculated on a dry matter basis. For an obese horse needing to lose weight, that might even be less than 1% of their current weight initially. You absolutely need a feed scale to weigh the hay accurately.
No guessing.
No guessing. Using slow feed hay nets is also great, makes the hay last longer, mimics grazing, keeps them busy.
And how fast should they lose weight?
Gradually. Aim for about 0.5 to 1% of their body weight per week. Monitor their body conditions score regularly. Avoid crash diets that can cause other problems.
Okay. With all this restriction, hay soaking, are they getting enough vitamins and minerals?
That's a crucial point. With restricted hay intake, and especially with soaking, they likely won't get enough essential nutrients. So a ration balancer pellet or a comprehensive vitamin and mineral supplement is absolutely essential, non-negotiable.
Any specific supplements often recommended?
Magnesium often comes up as it plays a role in insulin signaling. Chromium is sometimes mentioned too, but the evidence for it in horses is less clear-cut. But a balanced overall supplement is key.
All right, diet is covered. What about pillar number 2? Exercise.
Exercise is hugely beneficial if the horse is sound.
Big caveat there.
Massive caveat. Regular controlled exercise improves insulin sensitivity, helps with weight loss. You want to gradually increase the duration and intensity as their soundness allows.
But absolutely not if they have active laminitis.
Absolutely not. Exercising a horse with active laminitis risks causing catastrophic, permanent damage to the hoof structures. Soundness must always, always come first. Wait until they are fully recovered and cleared by your vet.
Okay, crystal clear. So what if diet and exercise, even done perfectly, aren't enough to get those insulin levels down? Is that when medication comes in?
Yes, medical management is used as an adjunct, a helper, when diet and exercise alone aren't achieving the goals.
What are the options there?
One common one is levothyroxine sodium, brand name Thyro-L usually.
Thyroid medication. But you said they usually have normal thyroids.
Correct. Most DMS horses are euthyroid. We use Thyro-L not because they have a thyroid problem, but because it increases their overall metabolic rate. This helps promote weight loss and can improve insulin sensitivity.
How long do they stay on it?
Often short-term, maybe 3 to 6 months, while focusing on diet and starting exercise. Then it's usually tapered off. Another drug you might hear about is metformin.
Used in humans for diabetes, right?
Yes. In horses, the idea is it might help reduce glucose absorption from the gut. But honestly, its effectiveness in horses is pretty limited because it has poor bioavailability, meaning not much gets absorbed into the bloodstream.
So maybe not the most reliable option. Are there newer things showing more promise, things people might be reading about?
Absolutely. And this is an exciting area. The sodium-glucose cotransporter 2 inhibitors, or SGLT2 inhibitors, drugs like velagliflozin or tugliflozin,
How do they work?
they work in the kidneys. They block glucose from being reabsorbed back into the body, so the horse essentially pees out excess glucose.
Wow. Okay.
This leads to a rapid drop in blood glucose and consequently a significant drop in insulin levels. They've shown really good effectiveness, sometimes quite dramatically lowering dangerously high insulin, even in urgent situations.
Other downsides?
They're still relatively new in equine medicine. Vets monitor for potential side effects like dehydration or urinary tract infections, but they are proving to be a very powerful tool in the toolbox.
Any others?
Well, if the horse also has PPID, then pergolide, the main drug for PPID, can sometimes help lower insulin levels too. But it doesn't replace the need for strict diet control for the ID component.
Right. So diet, exercise, maybe meds. Anything else in the management plan?
Yes, definitely hoof care, especially if there's been laminitis. Therapeutic farrier is critical. Special shoes, pads, trimming techniques to support the hoof, relieve pressure, and encourage proper healing and growth. Even for non-laminitic ID horses, regular balanced trimming is important.
And keeping track of how things are going.
Absolutely. Ongoing monitoring is vital. Regular body condition scoring, weighing the horse if possible. Periodically repeating blood tests like the OST to see if the management plan is working, are insulin levels improving. And just constantly watching for any clinical signs, subtle lameness, changes in those fat deposits. It really is a continuous process and a partnership with your vet.
It sounds like a lot of commitment, but manageable with dedication. What's the overall outlook?
The prognosis can actually be quite good for managing the condition and preventing future laminitis if there's aggressive, lifelong owner compliance with these management strategies.
Compliance is key.
It's everything. ID can't be cured, but it can be controlled effectively in most cases. However, if it's left unmanaged or managed poorly, the prognosis is guarded to poor because the risk of repeated debilitating laminitis is just so high. Early diagnosis and consistent intervention really are crucial for a good long-term outcome.
So reflecting on all this, what does it really mean for you listening right now? This deep dive into equine insulin dysregulation, it just shows this incredibly interconnected system within our horses, doesn't it?
It really does.
Diet, exercise, genetics, even other hormones like with PPID. It all weaves together to impact their health. Seeing those connections is a real aha moment. And understanding these details, these nuances, it isn't just, academic knowledge for horse owners. It feels foundational. It's about preventing pain, promoting a long, sound life for these animals we care so much about.
Being proactive, not reactive.
Exactly. Really understanding the language their body is speaking.
Which leads to an interesting thought, doesn't it? We've talked about the importance of continuous observation, watching weight, BCS, clinical signs. Given how critical that ongoing adaptation is for managing ID, how might integrating new technologies change things? Think about remote monitoring tools for equine health, maybe going beyond just weight and condition scores. How could that further revolutionize preventive care and allow for even earlier intervention in the future?